Very special person and a close friend of mine, Dr. Dandashi from Edmonton. He's a staff consultant, psychiatrist, and a lead physician of a neuromodulation program at University of Alberta and the Royal Alexandria Hospital in Edmonton. He finished his residency in psychiatry in 2010, and he had done a postdoctoral fellowship in stroke at the Department of Neurology, University of Alberta from 2001 to 2005. Please welcome with me Dr. Dandashi.
Thank you for having me here in Oakville today. I was threatened by the weatherman before leaving Edmonton that it's going to be minus 27 this week. So I'm glad to be in this weather. I'm part of the team of volunteer. We work together. We receive the support of UOSSM Canada and International and the SAMs of the States. Under their support, we could deliver a mental health service to people in need in Syria. Back when the conflict started in March of 2011, people started protesting all over the world in cities, condemning the killing of people. Me and some other friends went in front of the parliament in Edmonton, and we drew a map of Syria. We lit candles, and I remember at that time, after the conflict started, it was a couple of months later, we wrote a number of how many people killed at that time. It was 900. It is devastating to reach 470,000 people dead in Syria. These are just the number to tell you about the reported death in Syria. In 2013 November, there was a statement from the UN Refugee Agency. Every 30 seconds, a Syrian child becomes a refugee. They were living in a very nice country. It's a beautiful country. It was peaceful. What happened? This is how Syria now. We've never seen such horror by the Human Rights Watch. These people have become refugees within Syria and outside Syria. Numbers reach to millions. 6.5 millions of Syrian, they're refugees within Syria, and up to 5 millions, they're seeking resettlement outside Syria. More than 10 million displaced, more than 13.5 million in need of help. I will be talking about the mental health aspect of the refugees, and more specifically of the Syrian refugees. The World Health Organization defines the mental health as a state of well-being, recognition of each person's ability, being a contributor in the community. Not everybody who is a refugee will have a mental illness. Mental illness is a medically diagnosable illness. It's alteration and change in the way you think, the way you feel, the way you behave, or a combination of the above. The risk factors, though, that makes these refugees having a mental illness, more specifically the trauma, the hardship, imprisonment, losses, the poverty, the isolation, racism. The good news that not all refugees will have a mental illness. And those with mental illness, they may do just fine. Another good news that there are protective factors that you could work on in the hosting countries. And that's what most of the programs for refugees based on. Economic security, access to support service, education, supportive families, and participation in community groups. And we see the refugees, the Syrian refugees that they are coming, the more you involve them with the community resources and the community participation, the better they do. We could summarize what would happen to someone who was forced to leave their country and their home with risk factors divided in between the pre-migration, migration, and post-migration. What would happen to them after they are forced to display violence, persecution, family separation, social disruption, and poverty? Most importantly, and this has been replicated in several studies, even before Syria's war, that the violence, the physical violence, and mostly the sexual violence can leave sequela and can be a high risk factor to develop a mental illness, and a serious mental illness. I've heard stories about sexual abuse with refugees in the camps and during their journey until they reach here. After they migrate, difficulty meeting basic needs, lack of protection, experience of violence, fear of their own survival, overwhelming uncertainty about the future, the family separation, and adaptation to the new world. With those risk factors, the refugees are at high risk to develop mental health issues. Most importantly, the traumatic experience. Even after resettlement, they are still prone to have a mental illness, such as depression, post-traumatic stress disorder, many years after the resettlement. We don't have a reliable predictive prevalence of what would happen to the Syrian group or to the Syrian refugees in terms of their mental health. In 2015, the UNHCR predicted a 12 months study that these numbers may double. 2% to 3% may double to 3 to 4 after 12 months of their trauma, being a refugee. In terms of severe mental disorder. Mild mental disorder, again, it may double from 10 to 20, and no estimates on the adjustment. That being said, why refugees are at higher risk of developing mental illness? Probably they don't have an appropriate health care to start with. No wonder after their 80% of hospitals partially or completely destroyed. 75 of doctors fled their town. You may have seen this picture saw the video, or both. This is Omran. Omran was living with his parents and siblings in the rural Aleppo. One day, airstrike destroyed their town. He's sitting in the orange chair in an ambulance, pale, alone. He's not feeling his physical trauma. He's mostly having a psychological trauma. Omran has been a symbol of his country's devastation. Omran is in need of urgent psychological treatment. Me and other group of volunteers thought of doing something. Yes, we deliver mental health care. I'm not suturing wounds anymore. I used to do that when I was an emergency doctor. But at this point, I can suture a psychological wound. We have the tools. We could do it. We started a project of doing a neuropsych clinic, which involved neurologists and psychiatrists in Canada and United States, remotely through Skype service. We started as a pilot project in 2013 in the southern Turkey. Moved on, with the help with the UOSSM International, we moved on to northern Syria, to a town called Termina in 2014. And we have been ticking since then. Last year, we had the approval of SAM's US, that they have been helping us to do so. The service, these are my colleagues, 7 adult psychiatrists, 2 child and adolescent psychiatrists, 2 adult neurologists, and 1 pediatric neurologist. This is the clinic in Syria. I have the similar desk at my home, and that's how I operate. There's 1 clinical psychologist there. This is our pharmacy, and this is our pharmacist there. 2 psychologists, 1 psychiatric nurse, and we have administrative and logistic staff. We deliver, aside from giving medication, we deliver psychotherapy, cognitive behavioral therapy, most importantly, prolonged exposure therapy and cognitive processing therapy for people with PTSD. And imagine how many of them there. Family therapy, supportive therapy, and psychoeducation. We have a mobile service as well. The staff at the clinic can go to serve other areas. We serve 7 refugee camps there, orphanage, center of women, and the high school. Their telephone is 24/7. People can contact them for crisis. This is proven therapy. You could do telehealth, you could do telepsychiatry through Skype. It's effective. It's easy to have access to care. It's cost effective as face-to-face. We got some limitation though. I do telepsychiatry in Alberta with remote areas in the north. Neurologists do as well. But internationally, it hasn't been studied yet. We have we may go through ethical and medical legal issues, administrative issues, impact on clinical process, Sometimes the internet is not working over there because they have no, at some point they have no electricity. We're using guidelines of the World Health Organization to do telemedicine. Section 6.2, treatment of individuals with severe mental illness. We have some data to share with you from the clinic that we operate. Total patient is more than 1,870 with a visitation ranging between 600 to 800 a month. 60% females, 40% males. The children, 12%. I think this number is higher at this point. Adults, 85%, and we do serve less number of geriatrics. Out of those people, displaced persons within Syria is 60%, and non-displaced is 40% from the local. Most of our work delivering medication plus psychotherapy 95% of the time. 50% of our patients are with mood disorders such as major depressive disorder and bipolar disorder. 30% with psychotic illnesses, and we've seen a trend of increase of incidence of schizophrenia with people in Syria. I don't know why. The prevalence of schizophrenia is between 0.6 to 1% all over the world. But this has been increased in our population. Maybe it's too painful to live in reality. PTSD and anxiety, 20 to 25%. I want to talk about a case, one of my patients. His name is Mustafa. Mustafa was 7 years old 2 years ago. He used to go to school every day. He has a dream to become a mechanic. After school, he visits his dad in his mechanical shop. And one day, airstrike took his father away. Mustafa came from school to see his dad burning to death in a car. Mustafa became a mute for 6 months. The only form of communication between me and him was me talking and him nodding his head. With the help of medication and the psychotherapy, Mustafa was able to smile and talk and play and drawing. One day Mustafa called me dad. I woke up my wife because I start my clinic at 5:30 in the morning. After the clinic finished, I said, I have another son. Wow. She was angry at me initially, but when I told her the story, she was happy. So we started small with the first visit. We started with the pilot project, then telepsychiatry clinic established. We're doing the training to expand our service. Where do we go from there? I think with the partnership, with the help of UOSSM International, UOSSM Canada, and the SAM, we could do something. You can't do something positive unless you care. And you guys being here, that means you care. I am confident that we could help the people of Syria further. Thank you.